landas ng medisina. Sabay nating hinarap ang pagsubok at paghirap, hanggang makamtan natin ang matinyas nating pangarap. Pagsikat ng liwanag sa unang araw ng Mayo, sa taon na tinadhana bilang ating sentenaryo, ay biglang natapos din 5 taon ng pagsisikap, 5 taon ng pagsasama sa oras ng saya't hirap. Tayo ang class ng 98, sa simula napakitang gilas sa loob ng PGH, may busilak ng utak at puso. Kailan ba'y di nagkulang sa talino at talento? Tayo ang class ng 98, hanggang ngayon may pakitang gilas. Salamat PGH, mayaman sa utak at puso. Kailan ba'y di nagkulang sa talino at talento? Ilang dekada pang tayo'y magkakasama, sabay-sabay tayo yumapak sa landas ng pagkakaisa. Sabay nating harapin tagumpay ng ating mithiin, karangalan at galing sa lahat ng ating gawain. Pagsikat ng liwanag sa bawat araw ng taon, pasalamatan natin Diyos na Panginoon, sa alaala at kwento natin ng katuwa at bighati, sa lahat ng pangyayari na naghubog sa atin. Tayo ang class ng 98, sa simula napakitang gilas sa loob ng PGH, may busilak ng utak at puso. Kailan ba'y di nagkulang sa talino at talento? Tayo ang class ng 98, hanggang ngayon may pakitang gilas. Salamat PGH, mayaman sa utak at puso. Kailan ba'y di nagkulang sa talino at talento? Yung medisina
Welcome to the UP College of Medicine Class of 1998 webinar series. As this year's Silver Jubilarians, our class is hosting most of the webinars this year on Mondays, Wednesdays, and Fridays, unless announced otherwise. Coming from our successful webinars last year, our 2023 theme is still primary health care in the era of universal health care. In this current webinar series, we hope to unlock knowledge and discuss interesting and relevant topics for primary care physicians, including GPs, family and community medicine physicians, occupational and industrial health physicians, as well as other allied medical professionals. Here are some reminders for a smooth webinar experience. Firstly, kindly turn off your microphone and video for the duration of the webinar. Secondly, We encourage you to participate in an interactive discussion at the end of the speaker's presentation. Feel free to type in your questions in the Q&A chat box in Zoom or through the comment section if you are watching on Facebook. They will be addressed in the open forum after the lecture. Let us now begin with a short ecumenical prayer. Almighty Father, we praise and thank you for this day. We come to you asking for blessings and help for our speaker, moderator, and everyone present right now. We pray for your guidance as we unlock knowledge together. We ask that you show us how to conduct our work clearly and with a spirit of joy and enthusiasm. Protect us from the illness of apathy and hopelessness. Instead, keep the fire and love in our hearts as we work together with our colleagues. We ask that you challenge us to reach higher and further to be the best we can be for others. Amen.
Right. I don't know if you can hear me, but good afternoon to everyone on Zoom and those watching via Facebook and UP Manila live streams. Before we proceed, let me introduce myself. As your moderator today, I am Dr. Ronald Cruz. I'm an assistant professor at the University of Massachusetts Medical School at Worcester, Massachusetts, in the USA. I practice internal medicine, adult primary care in Worcester, Massachusetts. And of course, I'm also a proud Silver Jubilarian this year from the UP College of Medicine as of 1998. Allow me to introduce our distinguished guest speaker, Dr. Marimel D. Reyes Pagkatipunan. She is a pediatric infectious disease specialist and medical specialist at the UP-PGH. She's also a clinical associate professor at the Department of Pediatrics of PGH. Today, she'll be discussing a very interesting topic. It's prevention of invasive pneumococcal disease. I think this is something very important that we have to address as providers. According to the CDC website, in 2019, pneumonia killed 740,000 children younger than 5 years old globally. So, and also, I don't know if you're aware, actually, I just learned this last week, that on November 12th, it is World Pneumonia Day. So this topic is very apt for the celebration. So Dr. Pagkatipunan, welcome.
Good day, everyone. I'm Dr. Jean Pagkatipunan. I'm a pediatric infectious disease specialist. I'll be talking about the current and future state of IPD prevention in children, and it's in your hands. My disclosures, all the content of the slides are from the sponsor, and I will be discussing the scientific evidences presented by the company. And there is no conflict of interest to declare. So let's look into, it's just not about pneumonia, but the pneumococcal disease has other invasive manifestations. So as you can see in this slide, you can start with a non-invasive pneumococcal disease, like your sinusitis, acute otitis media, and pneumonia without bacteremia. But it can also lead to an invasive pneumococcal disease, like pneumonia with bacteremia or sepsis, and meningitis. So these are the ones that are life-threatening invasive disease. So IPD occurs when your strep pneumoniae infects the normally sterile sites like your blood and your CSF. So it still remains to be a serious threat to children. So pneumococcal bacteremia develops secondary to your pneumococcal pneumonia or as a primary disease with no identifiable source of infection, and is the most common clinical manifestation of your pneumococcal disease in children less than 2 years of age. And pneumococcal meningitis is the leading type of bacterial meningitis in children, with the decline of diseases caused by your Haemophilus influenzae type B in this age cohort because of the use of the vaccine. And pneumococcal meningitis continues to be the most common type of your bacterial meningitis, even among adults. So the sequelae of having pneumococcal meningitis or meningitis in general would be hearing loss and other neurologic sequelae, which are common among the survivors. So what is the current state of your IPD prevention and its related diseases? So in the Philippines, we are one of the top 15 countries that contribute to pneumonia cases globally, especially in children. So this is the WHO data by 2020 that still shows the top cause of your mortality among children is still pneumonia. And local data shows that about 31,395 Filipino children under 5 years of age have died due to pneumonia in 2021. And 60,500 Filipino children were actually infected with the disease in 2022. So with the advent of your PCV vaccines, which are now also under or included in the NIP or the National Immunization Program of the Philippines since 2020, we have seen that there's a short increase in the number or the coverage of those who have completed 3 doses of your PCVs. But 71% during the 2022 coverage is still very low or low if you really want to prevent your pneumococcal disease. It has been recommended as a 3+1 regimen by our societies like PPS and PIDS-T in this calendar, but the NIP or our DOH National Immunization Program implements the 3+0 regimen. So which means they just give the first 3 primary series of the vaccine. So how are we being infected by the IPD or pneumococcal invasive disease? And it has been affected by being infected with virus and then developing a secondary bacterial infection. So the main age group at risk are actually children younger than 5 years and adults older than 65 years. So these are the extremes of ages. And it has been shown that influenza-induced tissue damage is greatest at around day 7 after infection. So an initial infection of an influenza virus causes the tissue damage in the nose or the mucosa. So with the alteration of the pulmonary host response, like the viral replications that alters the respiratory epithelium, then alters your mucus production and reduces the ciliary beating in the nose. And then there's epithelial damage that exposes more attachment sites for bacteria. And so direct binding of your influenza to your pneumococci promotes adhesion to respiratory epithelial cells and thus causing secondary bacterial infection. We have seen in several studies that the correlation of the decrease in IPD incidence in children is due to the decrease in number of influenza and RSV cases. However, there's no change in overall pneumococcal carriage. So this study suggested that interventions that target certain respiratory viruses through vaccination, like influenza, may be able to prevent a large proportion of pediatric IPD cases. So the future in the vaccine or pneumococcal conjugate vaccines. So as pediatricians, we have the power to decide. Considerations for the next generation are the following. We know that we have already the PCV7 and the 13 that have the or contain the causes for the majority of the diseases. But residual disease is still significantly smaller with large proportion in the first year of life. So that future PCVs, again, must do no harm. And then it has to maintain immunogenicity levels to continue the disease suppression. Also, immunogenicity loss versus the standard of care has increased risk for breakthrough disease, particularly the non-invasive types. All PCVs are not created equal. The manufacturing process and technology may impact the immune response and ultimately the clinical results. And the population-specific PCV vaccines with the right serotype composition are required to maximize the public health impact. So immunization also, knowing the serotypes and the vaccine choice, also affects the antimicrobial resistance of the strep pneumococci. We all know that if you get the disease, you have to treat the disease or the pneumococcal disease because it's a bacterial disease, so you give antibiotics. But if you give the vaccine, you will then indirectly prevent antibiotic resistance. So these following serotypes, like your serotype 3, 6, 19, 19A, and the new serotypes that are now included in your new vaccine, your 22F and the 33F, are the ones that have been seen to have increasing antibiotic resistance. So the decision making is that knowing the clinical data before you vaccinate your patient with the new PCV. So for every new vaccine in the market, they have to have a non-inferiority trial with the existing vaccine. So the new PCV15 had several clinical trials, non-inferiority clinical trials against your PCV13. And the clinical trials, or the 7 big clinical trials that they have done in several countries, have around 7,200 participants from 6 weeks to 17 years of age. And these are healthy infants, but they also included in the subpopulation some preterm infants or those with sickle cell disease or HIV, and those children who need catch-up vaccination. For non-inferiority trial, okay, the reason is that we don't have the correlative protection for your PCV yet, or for your pneumococcal conjugate vaccines. So we don't know yet the level of the antibodies that the vaccine has to, or the vaccinee has to develop, so that we can say that they are protected. But the levels, the margin or the non-inferiority margin that was set at 0.5 will show us that if the new vaccine has levels above this non-inferiority margin, means that the new vaccine is actually okay, or be licensed to be used in the market. So this slide shows us the IgG GMC level of your PCV 15, which actually is non-inferior on all the serotypes that are included in the vaccine. And as you can see here, even the serotype, for the serotype 3, the levels of your PCV15 antibodies are actually much, much higher than the non-inferiority margin. And it has been shown in this several studies that they have done that they compared the PCV15 to PCV13, and they have seen that for the serotype 3, on all the pediatric studies, have robust IgG response against your PCV13. Why is there a significant benefit for the PCV15? In 2018 to 2019 in the US, the top serotypes causing IPD in children for less than 5 years of age was still the serotype 3, which is already contained in the PCV13. And including, and then the other 3 of the top 5 serotypes that causes childhood cases of IPDs are your 33F, and then your 22F. Thus, your 33F and the 22F were actually included in the PCV15. And it also shows us, although the differences in serotype distribution may be due to some differences in transmission dynamics, population risk factors, and the vaccine use in the programs. The different countries have differences in the prevalence of the serotypes. But as you can see here, like in the US, Canada, and even in Japan, they still have serotype 3 as the #1 cause of their IPD. So when you decide, then you can you shift it to 13 to 15 at any time. So the study was done for interchangeability of your PCV13 versus your PCV15. And the design of the study is shown here, that for group 1, all of the patients will receive the PCV13 as a 4-dose series. And your group 2, 3, and 4 were actually mixed dosing regimen. So for group 2, there's 3 doses of 13 and then 1 dose of the 15. The group 3, 2 doses each of your 13 and then followed by 15. The group 4 is 1 dose of 13 followed by your 3 doses of the PCV15. And the group 5 are those who were given the PCV15 as the 4-dose series. And it has shown that the serotype-specific IgG GMCs for all the 13 shared serotypes, 13 days after the dose 4, were actually similar. So there's non-inferiority of the PCV15 compared to those who received PCV13. So we can conclude that pediatric patients who are started on PCV13 can be switched to PCV15 at any point in the series. So you can start or switch to PCV15 at any dose in the 3+1 regimen. So can it also be co-administered with other vaccines and to other special populations? So they also have clinical studies that shows concomitant vaccination of your PCV15 compared to PCV13 and co-administered with the other vaccines like your varicella, MMR, Hiberix or Hib, okay? And also for the other vaccines like your hepatitis B, okay? And this shows that PCV15 can be given concomitantly or co-administered with other routinely administered pediatric vaccines. For special populations, they have seen that sub-analysis for some of the clinical trials done, they have seen that for preterm infants or those less than 37 weeks of age at birth were actually randomized to receive either the PCV15 or the 13 in a 4-dose series. And it has shown that these preterm infants can be given the PCV15, and the response is actually similar to those in-term infants. For those with children with sickle cell disease, they have seen for children 5 to 17 years of age and receive a single dose of either 15 for your PCV13. For all the vaccine serotypes that are included in the PCV15, they have shown the non-inferiority to your PCV13. And so they can be given to children with sickle cell disease. And the last special population is the children with HIV infection, those age 6 through 17 years. And the design was actually give the conjugate, pneumococcal conjugate, and then followed 2 months later with the polysaccharide 23, because these are the immunocompromised population. And it has shown that they have very good response also to your vaccine. So can it be given as part of the catch-up vaccination? So catch-up means those who have not yet completed their primary series and would like to continue on with their vaccination. And they have also the studies, catch-up vaccination studies for children and adolescents from 7 months through 17 years of age. And this is also compared to your PCV13. So if a child comes to you at 7 months to 11 months who have not yet been given any PCV vaccine, okay, so that means that the catch-up for this age group will have to be 3 doses of your PCVs. Okay. And then the next population is from 12 months through 23 months. Again, they have not yet received any of your PCVs. So at this age, you have to give 2 doses of your PCVs. And for those 2 years old through 17 years of age who have not been received any of PCV vaccines, not fully vaccinated, or the completed dosing is with lower valent PCV, like 10 and below. So this population will receive only 1 dose of either your PCV or 15 or 13. And it has shown that for all this age cohort, the serotype-specific IgG GMCs, 30 days following the last dose of the vaccine were actually numerically similar between the vaccination groups. So it means that there's non-inferiority of your PCV15 to your PCV13. So it can be given as a catch-up for catch-up vaccination schedule. For the safety profile of the vaccine, and they have compared all of this and have observed that they have similar profile for safety, and they are actually very benign. So the vaccines both are actually can be given safely with no serious side effects. So but the most important question is, will you be committed to increasing the vaccine coverage rate in our country? So why do we need to increase the vaccine coverage rate? Specifically for your pneumococcal conjugate vaccine, because it can contribute to developing herd immunity and can lead to drastic reduction in incidence of and transmission of the disease. So increasing vaccine coverage is future-proofing the health of the country. The vaccines are in our arsenal. So we all the vaccines that are here in the calendar, the childhood immunization schedule calendar, are available locally. It's like your flu vaccine, your COVID vaccine, and your PCVs. And soon, hopefully very soon, will be your RSV vaccine. So for our dear Tito and Tita docs, the future against IPD is in your hands. Thank you very much for your attention.
All right. Thank you, Dr. Pagkatipunan. That was a very comprehensive and educational presentation. As we begin our open forum, we'd like to thank our sponsor, MSD, for helping make this event possible. For today's webinar, we're going to do something different. Okay? Our speaker has kindly pre-recorded her answers to some of the most common questions asked about the topic. So let's watch this short video together.
So the question is on the efforts that can be done in a national setting to improve vaccine coverage. Definitely it should start first with physicians at their level, so that it would improve vaccine coverage in the community. So number one is to first know if these vaccines are now available, locally available, and then offer to your patients these vaccines, because we all know that vaccination is still the number one strategy to prevent and even to eliminate a disease. So it's not, the contribution is on a personal basis. So a physician giving a vaccine to your patients would really help improve the vaccine coverage rate in not only in your community but also in the national setting. So let's try to have extra effort on knowing these vaccines, how they are being given, the recommendation for the vaccine, and then give or offer the vaccine to your patients. So I have discussed about the nasal carriage of both your viruses and bacteria. So when you are infected, usually by a virus, it will actually be a factor to develop a secondary bacterial infection because of the mucosal damage. So when you have both the carriage of the virus, like influenza, And then they also have the um, pneumococcal bacteria there, your strep pneumococci. So when you develop a viral infection, it might lead to a secondary pneumococcal disease. And when you develop the pneumococcal disease, it may be non-invasive, but it can also be an invasive type. So what are the measures that can be done to prevent this? So we have the vaccine against the influenza virus, um, and also the vaccine for pneumococcal disease, your PCVs. Also, there are other vaccines for bacteria that are also in your nasal carriage, like Haemophilus influenza type B. So you get those vaccines also. The most important thing to be considered by the upcoming vaccines, like your PCV15, they have considered the factor on the immune response, so non-inferiority of the new vaccine or the PCV15 against the existing PCVs. Okay. Next would be the safety of the vaccine. So it has shown that it has have this. It doesn't have the safety concerns that we are trying to avoid when you get vaccinated. Okay, so it's immunogenicity, safety, and the factors that are very important would be the addition of your serotypes, like your 22F and your 33F, which are the significant serotypes that have been circulating for the past several years. And so, the addition of these two serotypes would actually increase, again, the coverage of the vaccine so that it will be able to prevent the diseases caused by these serotypes now included in the PCV15.
All right. So unfortunately, Dr. Pagkatipunan won't be able to join us for live. I guess you're just stuck with me. So what we're gonna do is actually, so mind you that I'm not a pediatrician, but I am an internist, so an adult primary care doctor. So I'm also familiar with the Prevnar 15. I'm sorry, the new PCV 15. Okay. So what we can do is actually going to give you the use of the PCV 15 in adult primary care. So so the PCV 15, so the pneumococcal vaccine that we give in adults. So there are actually three. So there's PCV 15, the PPSV 23, and also the new one is actually the PCV 20. All right. So the indication right now is anyone who's actually 65 years old and above, you can give the PCV 20, or you can give the PCV 15. And then after 1 year, you have to give the PPSV 23. Now, if the patient is immunocompromised, meaning the patient has, let's say, has HIV, the patient has malignancy, or patient has asplenia, then you can give the PPSV 23 2 months after the PCV 15. I hope it's kind of clear, right? So now, so that's actually for patients 65 and above. Now, for patients who are actually 19 to 64, you can also give the pneumococcal vaccine as long as they have underlying chronic medical condition. So when I say chronic medical condition, it can be a chronic lung disease. So if you have the patient has emphysema, the patient has chronic bronchitis, or even asthma, patients have chronic heart disease, patient has a congestive heart failure, they had a CAD, coronary artery disease. Hypertension is not actually considered as an indication for this pneumococcal vaccination. Also, chronic, let's say, chronic lung disease, kidney disease, liver disease also is also included in that category. So those patients you can already give the PCV 15, and then followed again after 1 year you can give the PPSV 23, or you can also give the PCV 20, and then after that one they're all set, and then wait until they reach 65 years old. So let's go actually go over with a couple of questions. All right. Let me see now. So this was actually an interesting question. So good afternoon. What specific precautions or considerations should be taken into account when administering the PCV to immunocompromised children? And how can we ensure the safety and optimal immune response following vaccination? Okay, so again, I'm not a pediatrician, but in adults, I can say that actually there's no special precaution or consideration that you have to actually do in administering this PCV 15 vaccine or the PCV 20. And actually, it was mentioned in Dr. Mariela's actually slides that actually there was studies done that actually these medications, these vaccines actually are efficacious at the same time they are safe, even for people who are immunocompromised. Okay. But in practice, so what I do actually in my practice, as long as actually the patient they don't have any symptoms of like flu-like symptoms, like let's say they have dry cough, slight fever, slight chills, then you can give the pneumonia vaccine. So if they have those symptoms, try not to give the vaccine to them. It's not really contraindicated if the patient they have symptoms. It's just that remember those vaccines, their side effect, they can cause myalgia, then they can cause actually chills. So you might say that if the patient develops those symptoms, then you might actually claim it to the pneumonia vaccine, and they will say, hey, I will not take that vaccine anymore. So it's safe as long as they don't have like a flu-like symptoms. You can give the pneumonia vaccine, including to patients who are immunocompromised. Okay. Now we have a next question here. All right. Good afternoon, Doc. How will you also compare PCV 13 to PCV 10? Can they be switchable anytime for the complete 4-dose series? Okay. So in adults, we don't use the PCV 10. I know in children use the PCV 10. But from what I know, so remember, there are different kinds of pneumonia vaccines. So we have the PCV 10, PCV 13, the PCV 15, PCV 20, and the PPSV 23. All right. So each one, they have a specific target serotypes. Okay. So from what I know, so remember, from Dr. Mariela's actually lecture, the common actually serotypes which cause severe invasive pneumococcal disease are the serotype 3, serotype 22F, and also serotype 33F. PCV 15 and also PCV 13, they actually take care of that actually serotypes. PCV 10 doesn't include antigens, or it's not effective for serotype 3, 22F, and 33F. All right, I hope that's clear. All right. All right. There's another question. Let's see now. Hello po. In the primary practice, how do we address flu-like illnesses? Just won't go away. And cold cough has been there months long. Even if it's treated, tendency is this flu-like illness keep on coming back again and then again. Unlike during the pre-pandemic area, para ang hirap gamitin ngayon ang simple po. Right. So, okay, I heard that there's actually like a virus going around right now. So what do you do in this case? All right, so if the patient has flu-like symptoms but actually lingers, so one, especially if actually it doesn't go away for 1 month, at least, especially if it actually is dry cough, in elderly patient, make sure that you order a chest X-ray. So sometimes patients who have malignancy can be have the same symptoms as patients who have chronic cough, right? Especially the dry cough. So, but then of course, besides that, most of the viral infections, you can treat them with just supportive care, just drink lots of fluids, rest, and then take over the counter, decongestant or cough suppressant. Okay. Let me see now. Any other questions? All right. So one question here, actually. What's the difference between PCV, so the pneumococcal conjugate vaccine, and the PPSV, or the pneumococcal polysaccharide vaccine? Okay, I think this came from a medical student. All right. So to review, so microbiology. So remember the bacteria, it has the cell membrane, then it also has its cell wall, and then it also has the, what we call the capsule, which is composed of the polysaccharide. So the pneumococcal polysaccharide vaccine, it contains the capsular polysaccharide antigen. And that's actually what we give to the patient. Okay. The PCV, the pneumococcal conjugated vaccine. So it also has the capsular polysaccharide antigens, but then they bind it with a inactivated diphtheria toxin. Okay. By doing that, it increases the immunogenicity of the vaccine. So meaning that the immune response will be more robust. So, and also the antibodies will actually be, the antibody level will actually be higher compared to the PPSV vaccines. All right. Let me see now. Thank you, Doc, for my question. Okay, you're welcome. All right. All right. So I have a 5-month-old baby, okay, who need to have PCV. All right. So unfortunately, I'm not a pediatrician. I can't really answer that one. All right. So I guess that's the end of the question and answer portion. I'm already giving like a signal that I have to go on. All right. Once again, thank you, Dr. Pagkatipunan. We are grateful for your time and expertise, and present you with this certificate of appreciation. Okay, Class 1998 would also like to thank those who helped make this webinar possible. The University of the Philippines, Manila, the UP Medical Alumni Society, the Postgraduate Institute of Medicine, the UP Information Management Service, and of course, our sponsor for today, MST. We invite all our viewers to join the next webinar on BRCA in breast cancer. Our expert speaker is Dr. Pamela Patu, a medical oncologist practicing at the Asian Hospital and Medical Center. The webinar will be held on November 10, this coming Friday at 12 noon also. You can use the same Zoom link to register in advance or use the QR code shown here. To receive your attendance certificate, kindly answer the evaluation form, which you can access through this QR code. We will also post the URL in the chat box now. You will be able to receive your attendance certificate only after answering the evaluation form. Please ensure that the name you enter in the form is the name format that you want to appear in your certificate. See you next time as we continue to unlock knowledge for primary care workers and allied medical professionals God bless you. Stay safe and happy holidays.